Our next presenter is Dr. Zev Schuman-Olivier. He's on the faculty of Dartmouth and Harvard. He'll have to tell us how he pulls that off. He's also the medical director of Westbridge Community Services in Cambridge. Zev is an addiction psychiatrist with a background in engineering and meditation and mindfulness, so he's a pretty complicated guy, I would say. How he pulls that together, we'll be hearing, I suppose. He's going to talk about integrated mobile platforms to support and monitor medication adherence in buprenorphine treatment. Buprenorphine, as many of you know, is a FDA-approved medication for opioid use disorders. It's effective. It's not widely available, but holds a lot of promise for the care of people with opioid use disorders. However, I think if all of us were to walk down Main Street to the Hanover Police Department and ask them what they thought of buprenorphine, well, they would probably first say, "What's buprenorphine?" But we would say, "Well, it's Suboxone." And they would say, "We don't like Suboxone. Suboxone's dangerous. People are addicted to it. They're selling it. It's the scourge of our existence." So as promising as buprenorphine is, I think it has also brought a certain amount of trouble to people in the community, law enforcement, medical care providers, a few of whom are in the audience today. Nice to see you folks. And I think Zev's approach is really an attempt to try to continue to make this powerful, effective medication, not a silver bullet medication, but effective medication available to the people with opioid use disorders who can benefit from it, but also to really kind of take into account issues around compliance, diversion, misuse, et cetera, so that it continue to be made available, but better monitoring system. So I'm really excited to hear your presentation, Zev, and glad you're here.
That was a great introduction. I probably can skip the whole first half of my talk now. Thank you. It's always nice when someone does that for you. I'm sorry that I didn't have it ready to load before, so need a second. Okay, it's encrypted for HIPAA compliance, right? Don't look at my password. There it is. Thank you for the invitation to come, first of all. This has been just so excited to be able to be associated with the Center for Technology and Behavioral Health and to be able to work on exciting projects like this. As he said, I am affiliated with a bunch of different places. So I guess just to start, and I think Mark make this point, is that prescription opiate abuse and heroin use, opiate dependence, which includes both of those, is a major serious public health issue right now. Over the past decade, opiate analgesics, prescription painkillers, actually surpassed all other drugs as the primary cause of drug poisoning deaths. As people have started to do all these prevention measures in order to decrease prescription pain medication abuse, actually we've just seen this transition to heroin and IV use has increased in the exact same time. And with that, we've seen a 70% increase in the last year here in the Northeast in Hep C rates among 20 to 29-year-olds, and obviously the risk for HIV as well. So what is buprenorphine? Just some facts, because I think, as Mark said, people know about Suboxone, but don't. I want to make sure everyone, as we start this conversation, to understand how it works, because it is a very special and unique medicine in the way that it works. It's a partial opioid mu receptor agonist that prevents opiate withdrawal. So unlike methadone, which is a full agonist and can cause euphoria in certain cases as well. Buprenorphine has this, it prevents opioid withdrawal, but it's only a partial mu-opioid agonist, so therefore there's a ceiling effect on respiratory depression. It's often co-formulated in the US with naloxone, which is a reversal opioid antagonist, and that's a deterrent. That's not absorbed in the body when you take it the correct way. If you take it, which is underneath the tongue, sublingually, if you were to take it IV or snorting it, then the naloxone can be absorbed and people will experience withdrawal if they already have opioid dependence. Buprenorphine binds more tightly to the mu-opioid receptors than any other opioid out there, and it holds on longer than almost any other opioid. So what that means is that if you take buprenorphine once a day, it will last 24 to 36 hours, and it will block your opioid receptors, the receptors that are responsible for the risk to respiratory depression. It will block those for the entire day. So if you do take buprenorphine, both you're out of withdrawal and it also is a blocking medication. So where is buprenorphine being prescribed? It sounds like from Mark's perspective, maybe not very much around here. Interestingly, there were 9.3 million buprenorphine prescriptions dispensed in the US in 2012. So if you assume that everyone maybe is taking it, a prescription once a month over the course of the year, then that means that there's close to 1 million people, 750,000 people, probably a little more than 1 million actually, because not everyone goes for the whole year, maybe more like 1.2 people. 1.2 million people that are being tried with buprenorphine in a year. And yet, if you look at the statistics here, in 2013, if you look at the national SAMHSA surveys, actually there are only 31,000 people in substance abuse treatment programs receiving buprenorphine, and in opiate treatment programs, only 7,409, and that's nationwide. So actually, where is all this buprenorphine being prescribed? And it's generally being prescribed in office-based opioid treatment, or OBOT, which is the abbreviation I'm going to use a lot. And and I should say that the OBOT system was developed by what we call Data 2000, and that was a bill that was supposed to bring addiction treatment out of the shadows in the corners and bring it right into the center of medical practice so that someone's primary care physician could treat their opiate dependence. And it wouldn't have to be something that people would have to necessarily always go to a treatment facility for. And that's what it has expanded access to care. So I just mentioned this briefly, I'm not going to get into the study, but Roger Weiss, who was one of my mentors at Harvard, was the director for the CTN trial, which is the Prescription Opiate Addiction Treatment Study, CTN 30. And this is important because what they did was a two-phase trial where they tried to detox people quickly off of Suboxone, or buprenorphine, and look at the effects. And then for those that were unsuccessful, they would put them on for 3 months, which was at that time seemed to be a long period of time, and then they would again taper them off and see how they did. And what's interesting is that actually in that very first phase, only 6% remained successful after the taper from buprenorphine. And so if you look at 12 weeks though, of that 12-week stabilization period, you have 50% of people remaining successful in opioid treatment. But as they taper over the next few weeks, at the end of the taper, they're down to 28%, and by 8 weeks post-taper, basically 90% of people have relapsed. So this paper really made the case for buprenorphine maintenance, and helping people get inducted on buprenorphine as a maintenance medication for opioid dependence, and then finding a way to help manage that. The problem is that Data 2000 waivers only allow us to treat 30 patients in your first year and then 100 patients after that. And so there's a limited number of physicians that are willing to prescribe, and that is the scarcity issue that Mark was talking about. The scarcity creates more diversion because people can't get it, so they try to get it in illicit ways. So retention of buprenorphine treatment is important because if people drop out, they generally relapse. And actually, when they relapse, their overdose risk will go up. So going into opiate maintenance treatment reduces the risk of overdose by 50%. And then as soon as people leave, there can be up to 26 times greater risk of overdose in the month after leaving opiate maintenance treatment. So why am I talking about medication adherence and all this? Well, this is a study that really got my attention. It was actually part of a CTN trial of young adults who were on buprenorphine for opioid dependence. And what they found was that young adults who took their medicine greater than 5 days a week had a strong inverse relationship with attrition from the study. So if they didn't drop out of the study if they took their medicine. It's just one predictor of many, but it was a very strong relationship, and that caught my attention. The other thing is that medication adherence in a recent study actually is a predictor for increased costs. So if people are non-adherent with their buprenorphine over the course of the year, then there are much higher healthcare costs than the folks that do remain adherent on their medication. So medication adherence is I don't know how, oh good, you guys, can you all see this? No, okay. So I'm just going to point out where the arrows are, and so we can think about some of the reasons that people might not be adherent to their medication. One reason is people actually discontinue their medication intentionally, and maybe they might tell you, which would be overt, or they might not tell you, and that would be covert discontinuation. And with regards to buprenorphine, we call that diversion, or often is diversion. The other way that people might not be taking all their medicine, they might be missing doses, and that might happen because of external barriers, it might happen because of internal barriers, or it might be a covert partial adherence. So just to nail this down, because I think it's important, is that people don't take their buprenorphine either because they lose their medicine, because there are financial difficulties, often insurance won't cover it, or there'll be gaps in insurance because you have to give in prior authorizations almost every 3 months with insurers in order to cover this medicine, but you don't with oxycodone, I shouldn't mention. There are adherence lapses, which are internal reasons, things like oversleeping or forgetting or loss of daily recovery focus. But it's these covert reasons we actually think are most important in buprenorphine treatment because we're working with people who are in recovery, early recovery from opiate dependence. And that is the covert discontinuation or partial adherence. That's selling or sharing some or all of it with others. And actually, most people in this situation, there's a study that shows, actually feel like it's a compassionate thing to do, to share your buprenorphine medication with someone else you care about. And covert partial adherence, which is basically generally ambivalence about recovery. So someone is thinking about getting high that day, and they want to avoid the blocking effect of buprenorphine on opiate euphoria, because most people, when they start buprenorphine, they try to use again, and then they realize that they don't get anything out of it, and so they don't want to waste their money. But they know that if they stop their medicine, at least that day, then they might be able to use. So those are the things that we really are trying to help with. There are several different types of based interventions, clinician-based interventions like motivational interviewing, cognitive behavioral therapy. You can use incentives and contingency management. There are telephonic reminders, such as the thing that I get whenever a pharmacy is calling me about a refill I might have, or you might as well. There are all sorts of electronic devices, texting, electronic reminders, and pagers. All of these are helpful for adherence lapses. But when it comes to the covert reasons for non-adherence, they're not particularly helpful. And that gets me to this buprenorphine diversion, which is what you started talking about. As you can see here, as buprenorphine has been prescribed more, and over the last 10 years, seizures from illicit buprenorphine or diverted buprenorphine have increased, actually, especially in our northeastern area. Oh, sorry, backwards. And this diversion is starting to threaten the regulatory framework that buprenorphine is being prescribed under. I'm not sure if people are aware, but I've been dealing with this a lot in Massachusetts, in that over the last year there have been actually 2 different bills, and one just came out, the one on the bottom there, 2133, just came out yesterday to try to regulate buprenorphine through the Department of Public Health and take it out of the ability of doctors to be able to decide how to prescribe. So this has been kind of an ongoing process, and I don't think it's just Massachusetts. So it's very important to figure out how to protect this medicine that is so helpful to people so that it can remain available and not have the lack of access issues that I think are possible. So here are some different diversion prevention interventions that are out there that are recommended. Urine tox testing, random pill counts, having short prescriptions, requiring a lockbox, doing in-office inductions with lowest possible dosing, mandatory psychosocial treatment, repeated inquiries about diversion and treatment, and making sure to check the prescription monitoring program. So people are doing these things, but unfortunately, if you're an office-based opiate treatment provider, let's say in rural Vermont, let's say you're part of the hub and spoke program, I imagine someone out here might be, it might take a lot to be able to do all these things, and we're doing them. And in other states, I think a lot of people aren't doing them because they don't have enough support from their state or enough organization in order to be able to do those kinds of things. So these are the diversion prevention interventions that are out there right now, and even all these things, they're always after the fact. They're not actually preventing diversion. Last thing about this and how I got to this intervention is that there's a clinical opportunity here too, because buprenorphine patients generally come to the appointments with their doctors. And if you ask them to go to psychosocial treatment, often it can be something that they will miss about half the time. It doesn't feel as important to them for some reason. So when people are coming to take that medicine, that actually, if you can tie medicine to treatment, in buprenorphine treatment, actually you get more attentiveness and more engagement. And I would say that moment when someone takes a medication during the day is the moment when they're deciding, I'm not going to relapse today, and I'm not going to overdose today. So what's needed? We came up with this idea for an integrated platform that could simultaneously ensure someone takes their meds, so they're adherent to their medicine, prevent diversion, prevent overdose, and enhance the potency of clinical treatment and recovery support. We were looking to try to come up with some idea that could be a remote platform that could be delivered at a low cost to a high volume of patients with a minimal burden on community clinicians and treatment programs. So this is what we came up with. And that is that at the center of it is the client or the participant, and that person is taking the medicine and they take it every day, once a day. We came up with the idea that they could use an electronic, secure pill dispenser that can't be tampered with in order to store that medicine. And when that medicine dispenser opens, we could do directly observed treatment and supervised self-administration by video conferencing. And this is similar to what happens in methadone. People have to come into the clinic and they get dosed every day, and people want to make sure they take their medication. So for the higher risk patients who are taking buprenorphine, which is actually about 50% that aren't retained at a year. So 50% of people it's not working for in the current structure. Those folks, I think that something like this could be very helpful for. So the way that it works is that the hub clinician would be the person who is doing these video outreaches, video check-ins every day, providing recovery support, like a daily recovery coach, making sure someone's taking their medication, and if they don't or anything comes up, they can give that information back to their local site clinician, who is their prescriber. And this is actually what the electronic pill organizer looks like that we have, and I do have one here if people want to see it. And the idea was, and we came with this idea of 4 R's, that the hub clinician would remind the participant to take the medication. They would establish a video connection and then record that the participant had taken the medication. If there was any kind of ambivalence about the medicine, then this is where instead of providing MI, motivational interviewing, at the very beginning of treatment 1 or 2 times, you could do it every day at the moment when someone is ambivalent about taking their medicine, at the moment when they're ambivalent about recovery, and help them to, MI doesn't always resolve the ambivalence someone has, but it gives you the best chance perhaps that you'd have. So help them to potentially resolve the ambivalence and take their medication. And if it doesn't work, well then we can connect them back with the relationship with their local treatment provider and let them know that they're struggling and they're having a hard time and could use some extra support. So we had primary aims. I'm not going to read each one of these, but we focused on feasibility, usability. We looked at some types of preliminary efficacy around adherence, diversion, and resource conservation, as well as acceptability in this proof of concept study. And what the study is that we did is we had a 2-week lead-in baseline period with 2 days of training people to use this platform, to use the video conferencing, to understand how the pill organizer worked before we left them alone at home with their medication. And then we had a 4-week initial platform testing period, and this is the data I'm going to show you today. And we asked them to complete weekly diversion, adherence, and acceptability surveys We also had this 360 data collection strategy. So we had the hub clinicians who were doing the video conferences also speak about their satisfaction and record the adherence from what they saw each day, as well as asking the local site clinicians who were associated with the local treatment center how they felt about it, whether it was acceptable or not. Just a quick word about the site. One of my affiliations, I work for Westbridge, which is a national nonprofit private co-occurring disorders treatment program with sites in Manchester, in Florida, and in Boston. And we implement the IDDT ACT teams, which I imagine most people here are familiar with, assertive community treatment teams. And we provide daily medication delivery. So at this site, we had 3 participants who were willing to participate in this proof of concept study who had co-occurring disorders and were receiving controlled substances. In this case, one of them had buprenorphine as the controlled substance and 2 were using stimulants. So the first primary aim, feasibility. We wanted to look at could we achieve at least 90% reliability in the function of these key components of the MySafeRx platform during the daily use for this 4-week period. And what we found was that we were able to establish video connection in 43.9% of the days during the study, person days in the study. We were able to get visual confirmation that someone had taken their medication via video on 91.5% of the days. And if you actually looked at the days that there was video connection made, then we were able to have visual confirmation of medication adherence on 98% of the days. So if you can make connection by video, I think that was one of the things that people doubted, like would you be able by video conference to be able to see someone taking their medicine and feel confident that they had? And in fact, we are able to do that. There were 2 days when things didn't work. One was that someone had actually tried to tamper with the device, which is always one of the questions, are they going to do that? But then it didn't open, so we had to go out and help them to open it and reset it and get their medication and coach them on not tampering with it. The other thing is that on one case, we did have an issue with video conferencing quality that made it impossible to be able to be confident that someone took their medication. So usability. There are many ways to measure usability, and we do have system usability scales at the very end of the study, but we don't have that quite yet for this initial part. But what we did want to look at was how long would it take to train people, and could participants with dual diagnosis, co-occurring disorders, be able to learn this complex system and be able to carry it out. So we had an idea that we would train people, and as soon as they got to 2 consecutive days when they got at least 90% right on the checklist that we had of everything they had to do, then they would be able to get started. And we hoped that it wouldn't be too long, because if it really took a long time, then that would make it very hard to be able to implement this. What we found is that the first day, on average, it was about 31 minutes of training time. Second day, about 23 minutes of training time. And overall, people only required about 55 minutes on average of training time. We did the first day of training in the office with them, and the second day of training, we would go to their home with them and do that there, while the hub clinician would be in the office. And all 3 of the subjects that we did in this proof of concept study were able to do it in the first 2 days. So that was a very, I think, positive thing, that it is doable and participants are able to learn this. Around preliminary efficacy. So looking at adherence, we wanted to see, again, looking back at this Warden study, that in all weeks that we could guarantee with this intervention that people would take their medicine on more than 5 out of 7 days, since that's so strongly linked to clinical outcomes. We also wanted to make sure that there were no reports of diversion during this trial. And we wanted to show, so Westbridge, as I said, it's an assertive community treatment team. So we do this daily outpatient medication delivery, and that's very time intensive. And when we talk about our program, when I've gone to different conferences and talked about our outcomes, people always say, yeah, but how do you afford that? Or how is that going to be applicable to the rest of the world? And so that's really, I think, one of the other motivators here was how do we take this model that seems to really help people to get into recovery and be able to make it something that everyone could be able to benefit from. And so we wanted to see, can we reduce the amount of resources that are necessary and the staff time and costs that are necessary if we do it this way. And this is actually, if you look at, on the left, the first 14 days is the baseline phase, and then we have a training days, and then as soon as a hub clinician takes over and is doing these medication adherence visits via video, what you see is a very substantial drop in the amount of staff time that is used, down from an average of about 30 minutes a day in order to guarantee medication adherence and diversion prevention to about 7 minutes a day. So the last thing is acceptability. And what you see here, 7 is completely agree and 1 is completely disagree. And clinicians, who are the hub clinicians who are doing this over video, generally actually felt pretty satisfied with the whole integrated platform. And if you look at the participants and the subjects, they felt pretty comfortable with the electronic organizer, they felt comfortable with the video conferencing, and they felt comfortable with the text messaging. So all these components we were putting together, they felt comfortable with. In this particular small study, however, it was about neutral, and maybe even a little below neutral for their satisfaction with the actual organizers, with the whole platform. So I've been trying to understand that, and we went back to the qualitative data to try to understand, well, why did that seem to come up? And there were some positive comments, and there also were some issues. So on the positive side, people really felt like the daily outreaches helped them to get up and get started in the morning. They were able to set goals every day with their recovery coach and meet their goals the next day and check on them and have that continuity. And I think that from a recovery standpoint is really important. Where the issues came up, I think, in this specific proof of concept study was that people felt like this program was a step back for them, that they had, they had access to their controlled substance before this at more extended periods of time, and now suddenly they're moving down to a daily medication dosing. They also, the organizer only opened at a very specific time of the day, so that was problematic because if they couldn't be available, then they would miss their meds. So the platform felt like it was a step backwards, and that is partly because this is designed, or the way we imagine this is for induction treatment with buprenorphine, and in this context we were giving it to people who had been on maintenance buprenorphine or a stimulant for an extended period of time. So they had already demonstrated the ability to be able to maintain it, and now here they were feeling maybe that it wasn't as helpful. So in the next study that we are planning, we hope to do this during the induction phase, when this will be for people who have either failed previous treatment or are coming in at high risk. So we believe that they will actually find it more beneficial from a satisfaction standpoint. And as far as the rigid time schedule, we have been looking to improve or use a medication dispenser that won't have the same time constraints that this ePill Secure pill dispenser that we've been using have done, but still be able to guarantee and ensure adherence. And you may have noticed that one of our 4Rs was our relationships, and one of the things we had hoped to do was if people didn't take their medications, they would maybe have a social support, like a sponsor or a family member they live with, be able to know and be able to go and help them. But people were kind of avoidant of that, and so at least in this stage, we've left it out for further studies. So the future plans for this MySafeRx project, we're hoping to submit a R34 application to be able to support PCPs in a community office-based opiate treatment program within a public hospital system across a region in the Metro North Boston area, to be able to support them in being able to ensure adherence and prevent diversion and improve clinical treatment for their higher risk patients. At Westbridge, we're hoping to use this to enhance our services and reduce the cost of medication supervised self-administration. And we're thinking about ways of potentially using this technology to be able to provide the kind of assertive community treatment supervised self-administration work that we're doing potentially to multiple other regions as well, and provide long-distance care. And ideally, I think where I think this could be really helpful is in larger community. In the larger community, especially in rural areas, where there's a lot of distance between where community providers are providing buprenorphine and where, may I say, a hub of with a lot of substance abuse treatment is located, so that it can be hard for people to maybe get access to all the additional support they need because of the distance. And so a remote, mobile platform like this might be able to offer an added benefit to ensure adherence, support recovery, and prevent diversion. Mark McGovern and I have actually discussed about how the Vermont Hub and Spoke program in some ways could be a perfect fit for this kind of opportunity. Similarly, in Western Massachusetts, a similar issue of difficulty with access to providers and difficulty with an access to substance abuse treatment and this whole integrated treatment approach. So I just want to express my gratitude to the Westbridge participants who are willing to participate in this proof of concept study, to our leadership board and our leadership team and the Westbridge board, to Lisa Marsh and Bob Drake and Mary Burnett, all who helped me to think about how to put this together, to our Westbridge technology team, which has put up with us and helped us with the video conferencing, to Jesse Schramm, who's out there, who did a lot of the clinical outreaches in the morning and was a hub clinician for us, and Rick Thornton, who was as well, and Jacob Bordowski in the back, who has been our research coordinator extraordinaire and dedicated the last year of his life to getting this whole project going. And he's in green because he's coming to Dartmouth and will be a grad student here. So you guys are lucky. Okay, so that's it.